Dear colleagues, this is a soft cataract, and in this case I am going to demonstrate divide and conquer technique. Since it is not possible to chop these soft cataracts, this divide and conquer technique was described by Dr. Vasavada. By this time we have made a main incision and one side port incision, and this is the patient is under topical and moving his eye. We have completed the incisions. Now this is capsulorhexis. The capsule has been incised, and with the help of ureter forceps I hold the capsular flap, go anticlockwise and make this rhexis. It is fast, it is guided, and if you practice using ureter forceps, I am sure you will use needle less often. Hydrodissection and hydrodelineation is done. A faint golden ring has formed in this case, and now viscoelastic substance is injected again, and now we are going to make a trench. In soft cataracts we cannot make a wide trench. It must be a narrow 1 tip width trench. The walls must be steep. Here it is. Make this sculpt in Phaco on mode and keep this width 1 tip width. Go deep and remember the contour of the posterior surface of the lens. The curvature of the posterior surface of the lens is more than that of anterior surface. So I am making a trench so that it looks like a plus sign, and when I can see the faint glow, I try to chop this, and I have been able to crack the nucleus. Now I rotate it 90 degree and I crack, and small fragment was released, it was removed. Now I rotate 180 degree and crack this. Now the nucleus has divided into 4 quadrants. Now I am slowly removing each quadrant. It is very easy to emulsify these pieces if energy required is only 30 to 40%. Flow rate in this case at this moment is about 400, and vacuum is flow rate is 40 and vacuum is 400 ml. Flow rate is 40 ml per minute and vacuum is 400 millimeter of mercury. Now cortical cleanup is to be done. This is a Simcoe cannula, and with this simple instrument cortical cleanup can be done very easily. If you are habituated to bimanual, it's good. I use this instrument because it saves my time. I give the Phaco handpiece to my assistant and immediately he gives me this instrument. The time to change the tubing is utilized. So the cortical cleanup and polishing of the posterior capsule is done. The idea is to clean the cortical matter nicely instrument is your choice. Now in this case we have selected a multi-piece lens, and I am going to enlarge the incision to 3 mm like this, because in multi-piece lens if I go inside the antechamber it becomes easy to guide the intraocular lens in the capsular bag. And if I increase the incision to 3 mm, I need not stress the incision. And stretching of incisions are more detrimental than a little cut. Now both the haptics of the intraocular lens has been placed inside the capsular bag. Now we're going to clean the viscoelastic substance, and you'll see that some white material, here it is, this white material that stick to the sensor multi-piece lens is flushed out and removed. In this case this white material is less, but in some cases you will see that this lot of white material sticks to the optic of the sensor multi-piece intraocular lens. There is something in the lumen, some talc kind of thing, which mixes with the viscoelastic substance and it sticks to the optic of the intraocular lens. The viscoelastic substance is cleaned thoroughly by irrigation and bimanual IA, and that's it. The case is done. You just have to use, this is a little moxifloxacin. I give moxi lavage. I will inject moxifloxacin and I will, at the end I will remove it. The side ports are hydrated, antechamber is formed, the case gets over. Thank you very much for watching. Hope these videos will be useful in your practice. This is the final wash under higher magnification. I want to see if I have left anything, if there is any little cotton fiber or anything sticking to the side ports, etc. Thank you once again.